suturing because it's so necessary. Hi family. So it is night 2 for me, and I was like, I'll just make another video. I know it's 3 a.m., but why not? I wanted to make this video to talk a little bit about how to prepare for fellowship, what things you can do where you are to help prepare you for fellowship. So if you are new to my channel, hello, welcome. My name is Dr. Yogi, and I have made this channel to document my journey from residency through Maternal Child Health with Surgical Obstetrics, hashtag go C-sections for family practice, experience, and then onward to jobs, and just to document what this looks like, because I just didn't find a lot of information or content on the web. So I said, you know what, let's make a channel. So here we are. And everyone who knows me, hi, welcome back. I'm so happy to see you. So let's get into the video. So step 1 to prepare, I would say get the most out of your residency training that you can. Because when you become a fellow, you are very much so in attending on the family medicine side of things. So make sure you're like milking your attendings for all the knowledge that they have. You want to make sure you're getting as many procedures as you can before you graduate so that you can do those skills in your family medicine or continuity clinic. You want to make sure that you are learning how to deal with all the chronic conditions that are known to family practice in multiple ways, because as you all know, every patient is different. There's no cookie cutter, and some methods work better than others. So just learning alternative ways to take care of your patients and manage their chronic conditions. Also try to learn as much as you can about billing, because you will be an attending, you'll get paid, not really on RVUs per se, because you're still a learner, but you'll need to keep those skills going through your fellowship year, because after you graduate, the likelihood that you get paid off RVUs or, pretty much productivity, you get paid for what you do, increases, right? The increased chance of having payment based off of the productivity or the work that you do. So make sure you are well versed as best you can be in billing. The second thing I would recommend is work on suturing. You can watch YouTube videos for this. You want to make sure that you're good in single-handed ties, both hands, as well as double-handed ties, with your lead being your left and your lead being your right. And when I say lead, I mean depending on how you throw your suture in whatever you're trying to suture, the open string or the string that you will need as the one you're tying will change depending on how you threw your stitch. So just being well versed in how to do your suture ties. And I would recommend actually getting a suture kit where it has a needle driver, so you can throw your stitch into something that is stagnant, that's not moving. So that way you throw it, and then you'll see your needle is attached to one side of the string, and you have to work on tying with the free end, because the free end will change. And I know it's probably confusing. If you guys want me to do a suture tying video where you see me struggle with the free end versus the non-free end, so you can see what I'm talking about, just comment below and I will definitely do that for you. I don't mind being embarrassed. And so I would definitely work on your suture tying. Double-handed knots, double-handed tying, and then single-handed tying with the left and right leading. Also take on more OB. So that would be the third thing I would recommend. Whether that means you're taking on L&D shifts, if you're a type of program that does drop-in calls like this program, the residents do these random 24-hour calls, and it could be on the OB service or the FMS service. So if that's the case, ask for more of those 24-hour drop-in calls. Or if you can cover OB, maybe you have a resident that's not interested in doing that, and you can swap calls. You can also see about getting a 2-week or a 4-week elective on the L&D service to boost up your skills, to boost up your time in the OR. And this is the time where you can ask your attendings, maybe you were a little sheepish before and you were just happy to be in on a C-section. This is the time you can say, hey, maybe talk to the scrub techs, ask them about, to walk you through their procedures and what things they're thinking about, or how to better assist And then you can get to the point where you ask your attending, hey, can I be the assist? Can I be your assist? They might be a little nervous about it. I wouldn't blame them because I remember when I first asked and an attending in residency gave me a chance, she was like, a piece of her was freaking out. But that is another thing you can do. Talk to the scrub techs when you're on L&D and ask them, to kind of walk you through the things that they do when they're first assisting, or maybe they have videos that you can watch. There's a couple on YouTube if you can just watch like good C-section videos that break it down. If I can find links to them, I'll include them in the description box below. But it kind of helps you go through the procedure, because the biggest thing you need to work on is knowing the instruments that are in the C-section, knowing that when they come in, like the steps of a C-section. It's like a dance. So once you learn all the important moves, all the important players, it gets easier when you're, the primary. So I would say do more OB shifts to increase your, not only your C-section knowledge, but your, knowledge and management of labor in general. Like, when do you want to put an FSC or a fetal scalp electrode? When do you want to put an IUPC, and why? And then in that regard, you can work on your definitions of understanding the fetal scalp. Understanding the fetal heart tones, like understanding classification. What makes something a recurrent decel? What makes something an intermittent decel? Periodic. All of those terms are important, because ideally you need to get to the language of OB, the language of fetal heart monitoring. So if you can, and I'll try to put some links below to that too, that if I can find any, but how to learn the definitions of classical fetal heart tracings. It's usually most people follow the National Institute of Health. There's a certain criteria that most people follow in the language of fetal heart tracing, so that way we all can speak the same language. So I will recommend that you look those up and become familiar with those terms. In clinic, try as much as you can to familiarize yourself with an ultrasound, the knobs on it, what they do, and just honestly the orientation. You can't really understand ultrasound any other way. Watching a video is, kind of helpful, and I'll link a video that I've found very helpful, but you have to get your hands on it, because the orientation and learning all that just comes with experience and practice. So if you can, ask about, doing ultrasound. Maybe ask if you can do a rotation with your your maternal fetal medicine specialist or perinatologist, because they usually have sonographers right in the office, or ultrasound techs is the other term. Or you can ask about being with the OB-GYN and say, hey, can I follow your ultrasound techs and try to learn the ultrasound? Find ways, create electives when there are no electives to get those OB skills. I would say try to spend some time learning the bread and butter of common OB complaints. Like when people come in for triage, what are the things they're coming in for? I'll tell you, a lot of it is labor rollout. So think about the steps you would do if someone came in concerned that they had ruptured membranes or broken their water, or they came in with first trimester or second or third trimester vaginal bleeding. So work through those bread and butter scenarios that come through triage, and that will better build your foundation. Also, from the bread and butter standpoint, you want to think about the very common high-risk parts of pregnancy, including the hypersensitive disorders. Like hypertension in pregnancy is a spectrum. So think about the definitions, learn about the definitions, what makes something gestational hypertension, what makes something preeclampsia, what makes something eclampsia, when is it considered chronic hypertension versus gestational hypertension, all of that jazz. So learning that bread and butter, learning things about gestational diabetes, at least the how to manage that. And you're not going to remember it all, because it's just like in residency, right? You try to study for residency, or you try to study like in med school, but nothing stuck until you got to residency. It's the same thing with OB fellowship. You can try to learn it, but it just doesn't stick until you're seeing it all the time, every day, all day. So don't be discouraged by that, but it's a good way to kind of get your brain into that OB mindset. The last two things I would recommend is, one, I would say practice Leopolding When I was in residency, I just did not do that. I was like, why do I have to guess with my hands if the baby is cephalic or head down? I could just put the ultrasound probe on the baby. But you might not always have that. So I think it's a good skill to have to feel what a cephalic or head down baby feels like and feel what a breech baby feels like. Feel what a transverse or a baby that is sideways, lateral in the abdomen. Feel what that feels like. Other things you can do with your Leopolds is guess the baby's weight. So how you can do that, one of my attendings here, I actually like the way he does this, but he said he looks at an IV bag, which is 1,000 milliliters or a liter, and he guesses how many liters are in his hand. So a liter is equal to a kilogram. So, if it's like, oh, there's like, 3.5 bags, 3.5 liters of saline in between my hands when I'm filling, then you can say that the baby's about 3.5 kilos, which turns to some type of pounds and ounces that I can't remember because I need my calculator. But that's kind of how you can get used to guessing Leopolds. If you have the luxury of having a midwife around, a good thing would be to go work with them, see all the tricks that they do, how they manage labor. I mean, it's just a different experience, and I think that it is very insightful to get an opportunity to work with a midwife. So do that if you have that opportunity. And then the final thing that I was mentioning was all your certifications that you had to get for residency. I would make sure that they are up to date before you graduate. That includes your ALS, Advanced Life Support, Advanced Cardiac Life Support, BLS, Basic Life Support, NRP, which you can do before or during you could do before or during fellowship. I never had that experience, so I had to get it when I came to fellowship. But that's the neonatal resuscitation. That's the neonatal resuscitation program. So definitely get that. And then your last thing would be your also advanced life support and obstetrics. You want to make sure that you are up to date on that before starting fellowship. So if you can get those things squared away before you come, that is the best ever, right? So those would be the things that I would recommend for you to do prior to starting fellowship. So anyway, I hope you guys found this helpful. Let me know in the comments below if you want me to, struggle through a suture tying workshop situation. And then I will see you guys in the next one.